Good evening and welcome to this first in the series of 4 free webinars from the BSP regarding the UK version of the EFPS 3 level guidelines. My name is Ian Dunn. I'm going to be your host for this evening. And before I hand over to the presenter for the evening and also to Professor West, who's just going to give you a bit of background on the guidelines, I'd just like to run through a little bit of housekeeping. The way the evening is going to run is we're going to start with our presentation from Professor Kebschull, and we will be taking questions as the presentation goes. You can type them into the question box on the bottom right-hand side of your screen, but we will be saving the questions until the end of the session. So Professor Kebschull will be talking for about an hour, and then we'll take questions at the end. I will pose the questions, and hopefully we will get an enlightened answer back from Professor Kebschull. Your STPD will be available after the presentation. You will be sent an email link from the BSP approximately in 2 to 3 days. You follow the link, you fill out the feedback, and then you'll be able to download your CPD certificate. So don't contact us tonight, say you can't get it. It will only be available in about 2 to 3 days' time. Please make sure after this evening's webinar that you sign up for the following 3 webinars so that you're registered for the whole series. Each webinar has to be registered on an individual basis. Hopefully that is the end of the housekeeping. There are no fire alarms tonight, so hopefully we can have an event-free evening. Before I pass on to this evening's main act, the headline act, I'd also like to bring in Professor Nicola West, who's just going to give a little bit of background and thanks to our sponsor for the evening, GSK.
Thank you, Ian, and good evening, everyone. It's a great pleasure to be with you all tonight. And as Ian said, this is the first of 4 webinars on the BSP implementation of treatment of stage 1 to 3 periodontitis, the EFP S3 level clinical practice guideline. I'm delighted to say the paper went online yesterday. A close call getting it published prior to Moritz's webinar tonight. So thank you, Journal of Dentistry. A huge amount of work has been put in by so many people to achieve this feat for the BSP. We held workshops throughout the summer, one good thing to come out of COVID, when 75 of our perio friends and colleagues, medics and UK stakeholders dolloped the European Federation of Perio S3 guidelines to make them fit for practice for the UK. And S3, for anyone who's wondering, as I was before I was involved with the EFP workshop, is the highest level of evidence providing recommendations in decision-making for consensus guidelines. This culminated in the publication of our paper, the aim of which is to improve the overall quality of periodontal care for our patients. The BSP has very kindly been sponsored by GSK to record several educational webinars and produce an animated flowchart resource that will be really helpful for everyone, I hope. That's out soon in March. It's interactive. I really hope you like it. And it'll be a pair to your classification flowchart on the wall of your practice. By creating these resources, we can help spread the importance of the educational message to the wider dental profession and patients and public. We're also writing a lay version of the guidelines for the public and patients, and that will hopefully be published in the BDJ shortly. And it was extremely important to the BSP to involve patients who could present their important views at the workshops, and they will be involved in the publication of that paper. We also have a dedicated page on our website for the S3 treatment guidelines, which can be found under the professional tab, and we'll continue to update this page with the resources that I've mentioned this evening to help you and your patients. And of course, we'll always answer your questions if you submit them to the BSP website. The BSP would like to realise their vision, periodontal health for a better life, and with your help, we think we can achieve that. I would like to thank GSK for their tremendous support on this project and for bringing our flowchart to life. I would also like to thank the BSP and those 75 workshop volunteers. Together, they've done an amazing job in a very short time. I'd like to thank the workshop chairs, Ina, our moderator, and very importantly, Paula Dunn, the BSP Executive General Manager, who has worked tirelessly with me on many late nights throughout this whole project. But most of all, I would like to thank you for your support and for joining us tonight. We'd like to hear your views and we'd like to share them with our friends and colleagues. You can make a real difference, and together we feel we can improve the health of the UK. I would now like to introduce to you Professor Moritz Kebschull. Moritz is a professor in periodontology at Birmingham University Dental School, and Moritz ran the EFP workshop, feels a long time ago now, Moritz, and also the German guidelines and the UK ones. And he was also involved in SEPA. He will be running the next S3 Level 4 guidelines for the EFP this summer and Endo guidelines. So I have to say, Moritz is an absolute expert at guidelines. I hope you enjoy the webinar. Thank you for joining this evening. And Moritz, I'd now like to pass to you for your presentation.
Many thanks. Oh yeah, many thanks, Danica, and many thanks, Ian, for introducing me so nicely. Indeed, it's my pleasure tonight to welcome all of you, dear colleagues, to the first of a series of 4 different webinars on the 4 different steps of therapy that are part of the periodontitis treatment guidelines. But before I even start to talk about steps of therapy, I have the pleasure to introducing you to the intricate world of guidelines and guideline developments and what they are all about. You may have noticed that Nicola has used funny expressions like a dolloping. I think, Nicola, nobody knows except for the ones that worked on this process that hard, all 75 of us, knows what a dollop is, but I think all 500 participants tonight will know after this 45 to 60-minute presentation. So what's the background? What is the reason we're coming together? The reason we're coming together tonight, and I think my screen is lagging a tiny little bit, but we'll be with you in a second, is that all of us are concerned with treating periodontitis cases, especially such severe cases like this one, where we can see a lot of disease, a lot of etiological factors, and massive inflammation of the gingiva. We also have to deal with cases on the other end of the periodontal spectrum, like this young lady, 27 years old, a non-smoker. Well, she for sure has an issue with her orthodontic situation, and she might need a nicer composite buildup on the upper right one. On the other hand, she looks fantastic gum-wise. So you see some orange skin like stippling of the gingiva. You see very little inflammatory signs. But if we, and I hope this builds up rather quickly, look at her PA status, and I think you will be seeing that now, you will see that this young lady has lost tremendous amounts of bone in very few years. She's only 27 years old and has very little amounts of risk factors that were detectable. So we have periodontal cases that either look horrible or impose not a very impressive clinical phenotype, but still come up with bone loss of about 50% and pockets in the centimeter range. Both ends of the periodontal spectrum, as we know, if we don't treat them effectively and efficiently and early enough, will lead to tooth loss, as you can see here. And whilst we all are well aware of how to do bridges, do dentures, place implants, and restore implants, it is still a big problem to lose a tooth. In addition, even worse, and I think this is a little bit difficult for the GoToWebinar software now to show, there are systemic ramifications of periodontal diseases. This is a video that I got from a cardiologist friend of mine who's on a regular basis saving lives. And you will see that there are 2 big vessels where there should be 3. If you remember what you have learned maybe years ago in anatomy, they're like the 3-finger rule of 3 big vessels. that are bringing oxygen to your heart. And in this case, we see a myocardial infarction, which is an acute life-threatening manifestation of atherosclerosis, a chronic inflammatory condition of the vessel walls that we now know is exacerbated and associated with severe periodontal disease, especially so, and this is work from my colleague in Birmingham, Thomas Dittrich, especially so in those patients that are very young and suffer from rapidly progressing periodontitis, like the lady in the second picture. Likewise, we also know of a lot of other more or less well-established associations. There is the famous saying that perio causes everything. We do know of a bidirectional relationship with diabetes mellitus type 2, and I will speak about this later because it's very relevant for the initial step of periodontitis therapy according to the new guideline. And we also have ramifications like rheumatoid arthritis, nephrological problems, and pregnancy complications. Some people even think that severe perio causes Alzheimer's or exacerbates its progression. So we can summarize, and I think that's a consensus, and I will use the word consensus a couple of times over this evening, that there is a well-established need to control periodontitis as well as possible, to treat it as efficiently as possible, and to detect the gum disease as early as we can. Now we come to a big problem, and I'm an educator, so I'm educating undergraduate students on an everyday level. The big problem is, well, how do I do it best? Who or what tells me what clinical procedures, what protocol does work best? And there we have a couple of options. First of all, and that's the generation of my parents who have also been dentists, they would always tell me, well, my professor 25 years ago or 35 years ago in dental school, he was very fond of this and that. So you would have an eminence-based treatment approach. What you learned at uni, or maybe what you learned in the CPD course, if you're a little bit more up to date, is what you will do. Others primarily work with what they have experienced in their own hands, the so-called clinical experience, and it's not totally to be dismissed. There's a famous Swedish periodontist who had the saying that clinical experience is doing the same wrong things again and again with increasing confidence. Well, and there's a little bit of truth in that. But I wouldn't completely dismiss clinical experience because there are so many holes in the third pillar of our knowledge, that is the scientific literature and research that people like I or Nicola are doing on an everyday basis if we can, and we don't have to run and get new masks fitted. So the big problems are, how can we get to clinical recommendations that are really based on what is happening in practice and where we can have big confidence in? And this is where we come to the different levels of clinical guidelines. Indeed, starting at the very bottom, there are recommendations of a panel of experts in an informal procedure to reach consensus. And there are quite a few of these guidelines or consensus reports out there, and you might come across them on an everyday basis. The issue with this is that typically it's a self-selected panel of experts, meaning an expert in a certain topic will call all of his or her friends to come over, have several bottles of red wine, and come to a conclusion about a certain topic. The issue here is that typically people the organizer disagrees with will not be heard, and that the recommendations can be easily skewed in a different direction. Therefore, the next better option and the higher development would be the S2C or consensus-based guideline, where we do not only invite our friends, but we would need to invite a representative guideline group of stakeholders from other disciplines, maybe also stakeholders that we do not necessarily like that much or that we do not agree with. And there would be an independent moderator, and we used a very resolute German surgeon for that, that will make sure that everybody, also the minority, will be heard, and that there's a structured way to come to a so-called consensus. So it is not the question who is left standing after 3 bottles of red wine, but it's the question what the majority of people in the room think after looking into a topic in a very detailed way. However, they might still look at only those studies they like or that they know. There's no appraisal of literature. This is typically done in an S2E guideline that is evidence-based, where you have a systematic review with a systematic selection and synthesis of available evidence and a grading or a very critical way of appraising the evidence. The problem is that neither S2E or S2C, these are the second steps of guideline developments, are really a good idea because you're always lacking something. If you do a guideline based on evidence only, you'll have a lot of black holes in there of areas that were not covered in the scientific literature. On the other hand, if you do a consensus-based guideline, you might miss stuff that is out there that you haven't read for some reason. This is why typically S2E and S2C are combined into the S3 level that Nicola has already mentioned in the beginning, which is the highest level of clinical guideline development that exists worldwide, and that's a world leading and accepted format that does both. That brings in systematic review or even systematic reviews. We had 15 different papers to work on in this guideline project, and combine that with the clinical expertise of a large group of representative guideline group members or stakeholders and to work on these data in a systematic, structured consensus process. This means S3 is actually the best you can get. It has both the systematic review in it and a representative guideline group. And indeed, as Nicholas said, I was part of the steering committee put into place by the European Federation of Periodontitis, the core countries of which you can see on this map in dark blue. But as you can see, that there's a certain trend towards world domination on the basis of the EFP, the European Federation of Periodontitis, by including European countries such as Argentina, Australia, or Taiwan. So we're looking at a very large federation that is the largest grouping in the world with 37 member nations, and our very own Nicola that had so kindly introduced me is their Secretary General, and I would say this is the unofficial boss. So kudos to you. This is the group that ran this S3 guideline format for the European Federation of Periodontitis, apart from me, so you cannot see me in this webinar tonight, to my great disappointment. I'm the rather big guy on the second to the left, and you'll see your very own Ian Chappell as the fourth to the right. And we have assembled, as I've said, both a systematic appraisal of the literature on all things periodontal therapy. So there are 15 systematic reviews that you can read for free in the Journal of Clinical Periodontology. And this was critically taken apart by a very diverse and large guideline group. So this is not only periodontists, but it is a grouping that included all different addressees of the guidelines. So people that would need to work with periodontal therapy in the future, including even the prosthodontists that maybe do not always agree with periodontists on an everyday basis. And we were quite lucky to publish the treatment of stage 1 to 3 periodontitis in the EFP AAP classification. That's everything that is defined by perio alone without prosthetic complications in the middle of last year. Now there's a little bit of an issue how to move forward from such a development and how to understand what really happened. I will now in the next minutes go a little bit into detail how the decision-making process in this very big group of up to 100 people, I think we were 90 something, would work out. Typically, you will use data from literature, the quality of the evidence on the very left-hand side, and go from the quality of the evidence to a strength of the recommendation. So one would assume that if you have very high quality of evidence, so if you have several randomized clinical trials or a systematic review and meta-analysis of many good randomized clinical trials, that's the best it gets. And these randomized clinical trials find that a certain method works or does not work, you would end up with a very strong recommendation that just tells you do that or don't do that. And the nomenclature for this is we recommend. Next, there might be more moderate evidence. Maybe you don't have a lot of randomized clinical trials. Maybe you only have cohort studies, you have case control studies, you have stuff from private practice where somebody looked at his or her cases over the last 15 years. That's a typical retrospective cohort, and they only have moderate quality of evidence. And this would typically not lead to a very strong recommendation because it hasn't been tested that rigorously. It would just be a recommendation that tells you, well, we think you should do that, you shouldn't do that, but it's just probable. And the nomenclature for this is we suggest. And lastly, you have low or even very low quality of evidence that could be cross-sectional studies, or it could even be case series. So unsystematic collection of a lot of cases. People like me or Nicola, we may have tried out a new method, and out of 10 people, 3 worked, and we have published 3 and said, well, these 3 are fantastic, but we haven't mentioned that the others may not be that good. So there's quite uncertain evidence. And the typical words to express this open recommendation is can be considered, or even we do not know. However, this is not an automatic thing. So we do not automatically, just because we have a couple of randomized clinical trials, go to a strong recommendation, because it needs to make sense. And there are a lot of things that we would take into account. And this is the job of the 100 people that you have seen before making the actual recommendation. So even though we have a lot of high quality evidence, this evidence would need to be relevant, and the outcomes would need to be relevant. There would need to be consistency and precision and a certain magnitude of study effects. You may have heard that people like me or Nicola or other profs have said, well, this is a significant result, but only because the study test, the statistical test, showed you that there's significance, it does not mean that it will be significant in your hands in practice. So there needs to be an appropriate clinical effect, and I will show you how we measured this later on, to make sense. And the whole thing needs to be applicable and make sense in a balance of benefits and harms. So if you gain 0.1 millimeter in probing depth, that might be beneficial for some. But if it costs 2,000 quid per session, it's maybe not such a good idea because the benefit is quite large. Or if you have a drug that could have a lot of side effects, we would need to see whether it really makes sense to use it, even though it might be beneficial. And you will hear quite a lot about this in the second step, where we have the situation that we do have a lot of high quality evidence, and we go from a very positive recommendation that would be the automatic thing to the very opposite. As I said, as a cliffhanger, Ian Chappell will talk about this in the next session. And there should be ethical, legal, and economical considerations. Maybe the product that was recommended in a European guideline is not available or is not allowable in the United Kingdom. And lastly, typically one introduces patients because they're the end addressee of a guideline, and it would need to be a measure or a intervention that is somehow nice enough for a patient to consider actually doing it. And all of these points can lead to an up or a downgrade of the evidence, as evidenced by these dotted lines here. So you can go from a very strong recommendation to nothing, and from nothing to a very strong recommendation. Typically only one step up or down, but we have seen one example where we go from a very strong do, we recommend strongly, to the exact opposite in step 2. And taken together, this is where the combined clinical expertise of all the members of the guideline group comes in. So you need somebody, and this is why we have so many people from diverse backgrounds, to really make sense out of the literature. And this is the beauty of the S3 guideline format. And indeed, there are ways in the 15 systematic reviews that we had to underline our guideline development to make a decision on clinical relevance. In the very right, you see there are red, yellow, or green boxes. And the red boxes are filled with a term NCR, non-clinically relevant. The yellow ones are potentially clinically relevant, and the green ones have an effect that might be statistically significant, but also clinically relevant. So we had to make a call whether the result of the evidence appraisal would actually make any difference in clinics, because typically, as you may know, in a single pocket, you would have quite a lot of difficulties to measure differences of 0.1 millimeters. If it's not a millimeter more or less on average, you can pretty much forget about this. So how do these recommendations done by the combination of the literature appraisal with 100 clinical brains look? If you look into the paper, and I think Nicola said we will link this on the BSP website, it's just came out on Monday night or on Tuesday morning, I don't even know, in the middle of the night. You will find quite a few boxes, 62 recommendations, and they all have the same format, and I will explain this to you here. First of all, we have the supporting literature that is typically a high quality systematic review, like the one from our very own Luigi Nimbale from London. And then you will see the grade of recommendation, and that's what I just mentioned. Either a very strong recommendation, we recommend; a not so strong potential recommendation, we suggest or we suggest not to; or an open recommendation, a 0, that says, well, you may consider doing that, but we are not so sure. In this case here on the screen, you see that this is a very strong recommendation, a grade A recommendation. We do recommend treating teeth with regenerative surgery. That's something that Nikos Donos will talk about in step 3. And this is supported by a lot of evidence, and it gives us a very, very strong support. Of note, there's also some information about the consensus in the group, because we had almost 100 people voting here, and it does give you an insight into how strongly the group felt by looking at the strength of consensus. So it makes a difference whether you had no consensus at all, or a simple majority, or unanimous consensus, where all members of the group said, yes, this is so true, and 100% support this notion. Importantly, you also see that there is abstentions due to potential conflicts of interest. As you may imagine, if you take 100 dentists, especially maybe clinical experts that give lectures, that travel the world, and you ask them to vote on measures that involve certain companies, it would make a quite problematic situation, because quite a lot of them, including me myself, we eventually speak on a conference or in a CPD course for certain persons. Sometimes you also consult them and we help them to develop better products. So it would not be meaningful if a person that has been paid tens of thousands or hundreds of quid in the last year from a certain company would make strong recommendations or strong for or against a certain product that is related to this company. So there is a measure built into this 3 format where everybody in the group has to openly declare potential interests. And then the group will go put their brains together and decide whether these interests that were declared do constitute a conflict of interest. And if that was the case, people would be kindly asked to not vote on recommendations. So in this case here, we had 10% of the group abstaining due to potential conflicts of interest. That would have included me myself, because I have lectured for both Sperman and Geistlich, who make regenerative materials in the past. I could still talk about it, but if I was the boss of Geistlich, I would possibly be asked to leave the room. So importantly, to give you recommendations that you can trust, they receive very strict protocol and framework for the control of potential conflicts of interest. So now we're looking at a guideline that was built for 37 nations all around the world. This is a problem because it is by definition a collection of supranational recommendations, a supranational guideline. So if you wanted to bring this into the United Kingdom, we would need to ensure that the guidelines are suitable for the healthcare environment and the culture and the specifics of the country, maybe also the medical legal implications. And to do so, there are different options. And about a year ago, maybe, when was it? No, it was Easter time, so it was not yet a year ago, like 9 months ago, I presented the following slides to the British Society of Periodontology Executive Board. There are different options here. So yes, we do have beautiful new European guidelines that are supranational in their nature. So you could go in and do a translation or a commentary. So thankfully, they were in some kind of English. I think, Nicola, you have done a lot of work to polish my German English and the Spanish contributions, Spanish English, into proper English. So if you want to read the original and compare it with the British version, there's a big difference and it's actually beautifully done. The problem is that even if you put up a commentary to translate what's in there, it would still not be able to take into account what is special about the United Kingdom, what is special about the NHS or maybe private practice in the United Kingdom. So it wouldn't be an ideal idea. Alternatively, and this is something that other countries may do, you can just say, well, I love it as it is, we'll just take it over. So you adopt it. The problem with adoption is that it's a good measure and it's a quick measure, but you do not always get the kit that you would love and that fits your interests and your family nicely. So this is why we looked more in detail into a third alternative, and that's the famous adaptation or the so-called great development. And you will remember that Nicola, in her introduction, has used the word to adopt, which is a new English word that we have just created, in a very natural way, because now, after running all these processes, it comes quite natural to us. But I would need to explain to you what this means and why this is a good idea. So, development is the most flexible option for implementation of a guideline, and we should not reinvent the wheel. This means you can take a higher level guideline, the one that we had, and we can use this framework for local uptake. And the word dollop is actually a new word that is put together from adoption, which means to take everything, something over, to look at the clinical recommendation, say, I'll love it as it is, we'll take it over. A modification, which means that you would agree largely with the recommendation, but you make subtle changes, or you change the wording, or you even change the level of recommendation. Maybe you would think that something that is very strongly recommended by an Italian author might only be possibly recommended or suggested in the United Kingdom because some things work differently here. And you could even bring in a de novo development, and that's the OLOP, that's in the dollop of individual clinical recommendations if you felt that something was missing. The whole thing is run as a big workshop that still needs to bring in the second part of the S3 guideline specifics. This is the representative guideline group. And indeed, we had, as Nicolas mentioned, 75 different stakeholders from 17 different organizations, so very broad range of people that we could bring in. And as suggested earlier, one of the big benefits of the pandemic was that first, most of these people had time during a work week at night, and we had Zoom, and Zoom allowed us to have very nicely structured conversations, and over a course of several weeks and months, we could come to a conclusion. And as Nicola has said, the Journal of Dentistry has just at the beginning of the week published our version of the BSP implementation, and I would urge all of you to download it. It's free of charge, so it's an open access document. So let's just look into the structure of what we have established here. It is a stepwise model that is proposed in the EFP guideline and its UK implementation. It starts with the first step, which is the basis of therapy, which is your everyday examination, assessment of risk factors, and a diagnosis. The EFP guideline calls for the use of the new diagnostic scheme that was introduced by the EFP and AAP in June of 2018. When you practice in Britain, you would typically use the BSP implementation that is considered to be more suitable for your local situation. And only after having fully climbed, as if you were climbing the stairs to get to your bedroom after this very interesting webinar, you need to fully climb the first step before you can climb the next one. So the next one would be that if you have diagnosed periodontitis using the EFP-AAP classification, you would initiate periotherapy and you would start the step 1. And I will be having the pleasure to introducing you to the different recommendations of step 1 in the second part of my lecture tonight, that is split into the introduction to guidelines and the step 1 mechanisms. This will include the control of local and systemic risk factors and a new term that we're introducing, the professional mechanical plaque reduction or removal, PMPR. And PMPR is, as you would say, a medical term for scale and polish, so a very thorough gingival and gingival cleaning of the teeth that is not focused on cosmetics, so it will never be liable for VAT, which is a good thing, and that has a better evidence basis than the scale and polish you're used to. And I will give you now some overview about what else is happening, but you will understand that this is not the topic of today's webinar, but will be covered in the next 3 ones by my colleagues Ian Chappell, Nikos Donos, and Nicola West, lastly for step 4. So once you have found adherence to the measures in step 1, and you still have pockets, you would go to step 2. That's what Ian will tell you about, everything about superficial instrumentation at adjuncts. And if you then still have pockets, you would need to go to step 3, and this is what Nikos will talk about in the coming weeks. This is the step for corrective periodontal surgery in certain cases with suitable patient tooth and defect factors. And lastly, if you have reached an endpoint, and we have now, and this is a critical new finding, an endpoint of ideally only pockets up to 4 mm without bleeding and probing, you can progress to supportive periodontal therapy in step 4. So let's just go back to the beginning, because this is what I'm talking about tonight. The basis of therapy, the diagnosis, risk factors, and step 1. So as I said, we will look at our patient, very closely examine the patient. This typically includes probing with a periodontal probe at 6 different sites per tooth. This depends on a couple of things, and if you haven't recently done it, maybe go through your practice, talk to your members of staff, and maybe assess how they probe, because some of your hygienists may probe very differently from you. And then you would take some kind of X-ray to assess how much bone has been lost. It does not necessarily always need to be a full PA status. This is something I typically do in cases with very severe or rapidly progressing periodontal disease. Quite often, if you have a very modern OPG device, you can combine a panoramic X-ray and a selected number of PAs. And then you can go in and put these patients into different stages according to the largest clinical attachment loss or bone loss, and add some complexity factors in the original version. I will come to the British version in a second, and give information about the extent and distribution of this patient and of this severity of periodontitis. Importantly, the staging, which is the severity, and the extent have to be combined with a grade for progression, and the grade is in 3 different levels. Grade B being relatively moderate progression over time, grade A being almost perio-resistant cases that are very, very slow in progression, and grade C being galloping periodontitis. The most important part for you to remember is that every patient, until proven otherwise, is assigned grade B, normal progression. And importantly, we will in clinical practice need to differentiate those with a normal progression from those with very fast progression. Typically, this is done either using longitudinal data or the ratio of maximum bone loss in % in the internal space and the age. So in summary, you would be looking, because you want to differentiate B and C, you would be looking for an internal space in your patient where you have more bone loss in % than the age of the patient. So looking at my 27-year-old patient in the second slide that I showed you, I was just looking whether I find more than 27% of bone loss, and I easily found more than 50% everywhere. So I was quite sure that she belonged in the highest grade, the strongest progression grade. And I've stolen a nice chart here from my colleague Ian Chappell, who was instrumental for the implementation of this scheme into Britain, and it looks quite similar to the original version, but there is a stage 4 introduced here. That is very severe disease that is characterized by mid-apical third and complexity factors, plus the grading as I've demonstrated to you before. Typically, and this is a development of the BSP that is hosting you tonight, typically this is what would be suggested to use when you are practicing on the British Isles, but to keep in mind, it is quite similar. It's an implementation to make it a little bit easier and less academic of the system the EFP has introduced together with the Americans. So importantly, this classification scheme is driving the different steps of therapy. So regardless of whether you have step 1, stage 2, or stage 3 disease, you will always need the first step of therapy that I'm talking about today, whilst substantial instrumentation and adjunctive measures will only be necessary in affected teeth that are maybe less frequent in the less pronounced cases in perio, whilst corrective surgery is something that would only be needed in stage 3 in the FP or stage 3 and 4 in the BSP implementation. And all patients, and that's quite important, so you all have to hop on Nicholas' webinar in the next month. You will need SPT because every perio patient is a perio patient forever. So let's maybe look at what's happening after making the diagnosis. So I have diagnosed using either the FP or the British interpretation of the EFP classification, which is pretty much the same thing. And whenever I make the diagnosis of periodontitis, I would initiate periodontal therapy, and this starts with the step 1. And step 1 is a control of risk factors first and foremost. And there are local risk factors that are predominantly plaque, calculus, overhangs, and systemic risk factors, those that are now understood to really drive periodontal disease. And the whole thing would be combined with the professional removal of local risk factors by using the new term, the mechanical plaque reduction, PMPR. So let's look into risk factors again, because one of the important ideas in perio over the last years is how important the different factors driving susceptibility are. So when I started to work in perio, most of our ideas, and well, I'm a genetic researcher, so I quite like that, most of our ideas were that everything that you have there is largely inherited. So people would bring a certain inherited susceptibility to periodontitis or would not bring it. But now it has been understood, and this is largely featured in the new classification scheme, that risk factors such as diabetes or risk factors that are modifiable such as smoking do play a major role in making our patients susceptible to disease, and vice versa, they play a big role in the treatment of the disease, and that's a major point in step 1 therapy. As you may very well remember, going back to your undergrads maybe, what's happening in diabetes. In diabetes, you have too much sugar in your blood, you have hyperglycemia, and when there's too much sugar in the blood on a pretty much everyday basis, on a long-term basis, you'll get a fusion, a non-enzymatic fusion of these sugars with proteins, and proteins are the little factories in your cell, and they will end up as glycated proteins that do not work as well. And you may be aware of the term HbA1c, which is the measure of how many red blood cells are glycated, and they give us an idea of how well a diabetic is controlled. The fortunate thing with the red blood cells is that they tend to be filtered by the spleen every 6 weeks, so you get new ones. In most other places in the body, the glycation end products, advanced glycation end products, AGEs, accumulate, and they lead by 2 different mechanisms. This is the 2-hit model that was published by Lala and Papapano in 2011. They lead to an impaired wound healing, and by being detected by macrophages, they would also lead to more inflammation. So on average, the periodontitis patient, even though this particular patient might brush very well, will have more inflammation and will heal very much less well. And this leads to a direct effect, and this is a study that I quite like because I know all the authors. Ryan Demmer is a good friend of mine. He's a guy from Minnesota that ran a study in Germany. If you compare over 5 years diabetes-free individuals on the very left with incident diabetes patients or uncontrolled diabetes patients, that's the fourth graph, you see a direct effect of diabetes and diabetes control on attachment loss over 5 years in this prospective cohort study. Importantly, and that's something to keep in mind, even though we are very good in controlling disease, the third graph is controlled diabetes, and still the controlled diabetes is worse off than the diabetes-free individual. So just because you have a diabetologist that is treating your patients in a very established and very predictable way, they will still be worse and they will still show more progression than those who are diabetes-free. Likewise, as a different mechanism that is also extremely prevalent in our patients, we have smoking. And smoking does not only have the 2-hit model, but it pretty much has a triple-hit model. So smoking, as we know, leads to decreased circulation, maybe even on a permanent basis. It leads to differences in the function of several immune cells. This is a macrophage. The next one is a neutrophil that cannot move as well as it would like to. It leads to a decreased function of fibroblasts that are important for healing, and we have a direct effect on the dysbiosis of the substantial microbiota. So you see an effect on defense, an effect on healing, and an effect on inflammation, and we might very well call this a triple hit model. And indeed, and this is a classical study that I quite like because it shows how well smoking accumulates, and we will see it in a second. There is a direct dose effect relationship between smoking and the cigarette smoked and attachment loss in this classical study. Typically, the risk in many studies is at least doubled or tripled. This is meta-analysis in the Linde textbook that gives an odds ratio of 2.8. What does this mean? This means that one of the prime ways to treat perio in a modern way would not only be to concentrate on plug on teeth. I will come to this in a minute, no worries. But first and foremost, to attempt risk factor control interventions. And there you see these recommendations from the guideline. There's a strong recommendation. This means you should do risk factor control interventions in patients in periodontitis therapy. And there are sub recommendations that say, most importantly, and this is also should do recommendation, are those interventions to stop smoking or smoking cessation interventions and to really control diabetes. As you've seen, diabetes control is directly linked to progression in the future. There are also some other more lifestyle related interventions like trying to reduce obesity, trying to move a little bit more or eat more healthily. And the guideline group felt that they would make a lot of sense, but the data are not anywhere as strong as the data for diabetes and smoking. So if tomorrow morning you start a periotherapy in a patient, your first idea would be, what are this individual's risk factors, systemic risk factors, and can I do anything to control them, either myself or maybe their GP or the diabetologist or some other healthcare professional? You will have missed plaque and biofilm because a lot of people say, well, it's only about removing mineralized deposits in biofilm and perio, which is not strictly speaking true, but it's still an important factor. And there are also areas with imperfect restorations where this removal, either by a professional and or by the patient in individual hygiene, is impaired. So imperfect restorations need to be removed or optimized to facilitate biofilm control. And here I have a very nice crown that has a little bit of pink porcelain that is totally non-cleansable. And if you look closely, I hope the picture is clear enough, you will see a super floss that some people use for bridges that could use a super floss to clean this overhang. And there is indeed a very strong recommendation, grade A again, that superficial professional mechanical plaque removal, PMPR, and the control of retentive factors, as the one just pictured, should be performed in periodontitis therapy. So again, what is PMPR? PMPR is a medical scale and polish that includes the removal of soft and hard deposits, supragingival, and typically also in the visible marginal area. The idea here again is not to go on your nerves with a new term, but to establish something in the scientific literature that actually has a lot of scientific support. In addition, we would need to make sure that the whole area is not only accessible to the institutionalized professional hygiene, but also to the everyday individual hygiene of the patient at home. The biggest problem here is that the patient has maybe not brushed his teeth properly for many, many years or decades. So there's a strong recommendation to emphasize the importance of oral hygiene and to engage the periodontitis patient in behavioral change for oral hygiene improvement. So we would need to find methods, and I think most of you know how we can struggle with that at times, to motivate the patient to do something different, to do something more thoroughly than they have done for the last 20, 30, 40, 50 years. And indeed, there's a whole field of research in this area that is focusing on how to do that, apart from staining plaque and giving little speeches. And quite a few of those use psychological techniques. A very famous one was motivational interviewing, and there are even full chapters in textbooks. But if you look on the very right-hand side, and I have marked everything that was non-significant between the groups in red, you can see there are quite a few of those studies that could be identified in the systematic review underlying these recommendations, where motivational interviewing and other psychological techniques did not really bring a big difference. Does it mean that it's all rubbish? Not necessarily. It's probably more the case that we are dentists, or maybe we're dental hygienists, and we're not psychologists. And there's a reason that they have to go to uni for a lot of years, because psychological techniques need to be done by professionals, and that's unfortunately not us. There is a summary that says, well, for implementing a behavioral change in perio patients, the available evidence, that's what you've just seen, does not support, because it's all red, a recommendation in favor of psychological methods such as motivational interviewing. That does not mean it's rubbish. Possibly if you're a psychologist, and or maybe if you're very, very nice and good with your emotions, there might be an effect in favor. What you can do, and there's a strong recommendation for that, is the strong recommendation for repeated individually tailored instructions delivered by you or by the dental hygienist in mechanical oral hygiene, and importantly, that should include interdental cleaning in order to control inflammation, and in addition to that, to avoid potential damage. Because one downside of motivating a patient to clean the teeth and the tissues as good as possible is that they might cause damage by being overly motivated to be by being overly vigorous, maybe doing things too strongly or too often. And you will have noticed, if you read this very carefully, that this recommendation says in periodontal maintenance. And this is a little bit of an intricate thing. A lot of the recommendations for hygiene are the same for step 1, which is the basic therapy before we do actual substitutional instrumentation, and for supportive therapy. And it was found that it doesn't really matter which step of therapy you're in, there would not be big differences. Therefore, I have chosen, whilst looking at the data here, to summarize the oral hygiene recommendations, but to make sure that you understand that they will be discussed in much more detail by my colleague, Professor Nicola West, in her Step 4 webinar, and she is a real expert in oral hygiene methods. So importantly, for the patient in Step 1 therapy, if you choose a toothbrush for this patient, you would need to take into account his or her needs and preferences, maybe also their abilities, because it makes a big difference whether you have a hand surgeon who is fantastic with her or his hands, or whether you have a person that has 10 thumbs or 2 left hands that would possibly not work as well. This is strongly recommended. However, there's no strong or any recommendation in favor of powered toothbrushes. They tend to be a tiny little bit better in studies, but it was debatable whether every patient would profit from this and whether this difference was actually clinically relevant. But the group felt that it would be meaningful to allow to recommend a powered toothbrush in certain cases where the dentist or the hygienist felt that they would bring a benefit. An important recommendation is that the standard method for interdontal cleaning that should be recommended to periodontal patients is the interdontal brush. So wherever you can get an interdontal brush into the pockets, you should use it, and you should specifically not use flossing as a first choice. So Nicola will likely go into more detail about all the different things. So there's a ranking. So first of all, there's internal brushes, and then there's a lot of different other things, and then there's flossing. Typically, flossing is nothing that a periodontal patient will benefit from a lot. And then there's the discussion about additional things, adjunctive measures to improve oral hygiene. And an important concept in periodontitis therapy is that the first and foremost measure that we should be recommending is the mechanical plaque control. And only in those cases where we feel that we have done everything we could, we may consider to bring in antiseptics to support us. And in the British implementation, these are specifically mostly mouthwashes or oral rinses. There has not been a consensus on a recommendation for a toothpaste in the British version. So in summary, I've told you about step 1, that comes after the examination, the assessment of risk factors and the diagnosis, and it focuses on the control of risk factors. That is first and foremost the control of overhangs, the removal of calculus, the removal of biofilm on an everyday basis by a motivated patient that has the correct tools to use those, and that is trained in the use of those tools, and the control of the systemic risk factors that include diabetes and smoking as the prime ones with very strong recommendations, but also other factors such as nutrition, lifestyle, and obesity. And the whole thing is coupled to the new term PMPR, where we professionally, with a medical intention rather than a cosmetic intention, remove all hard and soft deposits that we can see and reach in the oral cavity. Importantly, after doing step 1, and I typically use at least 2 sessions for that to be able to get an idea how well the patient works with me, I would need to make a decision. The decision is whether I have adherence. I have a patient that is actually working with me. And if this was the case and the patient still had deeper pockets than 3 millimeters, I would send the patient into step 2 therapy. If I have a lack of adherence, so I have a patient who's not working sufficiently with me, and this could be interpreted by a very high plaque index or by the lack of an improvement of plaque index. You may remember that the Scandinavians typically said where you shouldn't do substantial instrumentation or RSD in cases where you don't have a plaque index of better than 25%. There might be the case where you start off with 100% and the patient improves to 35, which is tremendous because it's a big achievement, but you would still say, well, it's not good enough. So as the rule of the thumb, and this is also endorsed by the BSP in the flowcharts that Nicola already mentioned, we would typically ask for a delta or an improvement of at least 50%. But I will not go into detail here, and I'm almost at the end of my lecture, and I can just say that Ian, my colleague, who's next door, will be with you on the 24th of February at 7 p.m. and give you an introduction into all these interesting things, especially about the different adjunctive measures and their relative value and recommendation in periodontitis therapy. With this, I'm already at the end. I'm just over an hour with all the introductions to give you a summary of what I've told you about. I've given you an introduction that might have been a little bit boring, but it gives you the idea what the whole process was about, that as 3-level guidelines, that's what the Europeans did, and that's what we brought into Britain using the development method that allowed for the inclusion of, let's say, location and healthcare system specific cultural differences. These guidelines combine clinical experience of a vast, diverse and representative group of users and end users with systematic evidence appraisal. That means we take the best out of the literature and we fill the gaps and we make meaningful thoughts and recommendations based on these findings using our combined clinical expertise. Next, it must be understood that the EFPS 3-level guideline and the UK implementation map to the new classification scheme that is based on a thorough understanding of the pathophysiology of periodontitis that is used all over the world, and that incorporates our new understanding of risk factors in the role of periodontitis. And importantly, the new guideline is the first step to actually fill these maybe a little bit academic discussions about classification with life, so it directly relates to different therapy in the new guideline. And lastly, you have seen 4 simple steps that are applicable to all levels of case complexity that we have at the moment. I'll show it again. You have seen the basis of therapy in step 1 with me today. The next one will be in chapel. Step 3, the surgical maneuvers, will be our own Nikos Donos from London. And lastly, our co-host tonight, Nicola West, will be talking about step 4, supportive periodontal therapy. And as I've said, I'm quite sure that Nicola will talk about oral hygiene in more detail. So I've just made it a little quicker because she's the expert there. And with this, I remain with many thanks for your kind attention. It was a great thing that we could support this wonderful project, even though it has cost me quite a lot of nerves, to be fair, because it was not so easy to coordinate different guideline groups with all these diverse interests. So it's always a pro to bring in diverse ideas, different viewpoints, but it's also making life a lot easier. At times, Nicola and I sat back and said, why did we invite these people? It's so difficult. And with this, I'm very happy to take a lot of questions from you.
Thank you, Moritz, for that really comprehensive explanation of the development process. I know when I was asked to be involved in this back in lockdown 1, doesn't that seem like a long time ago? I'd never even heard of the word development. I know the BSP were contacted by a few people who thought it was actually a spelling mistake. So hopefully your presentation has highlighted the concept of development and why it's such an important process for guidelines. So I do thank you for that. We do have quite a few questions coming through. So I will do what I can to work our way through them. Within the risk factor management, did the guidelines look at e-cigarettes when they talked about smoking cessation and risk factor management?
No, they have not yet done so, but they have looked into different medical guidelines, how to best do smoking cessation, and they have been managed in or have been mentioned in some of them, but there is a certain consensus that e-cigarettes might be beneficial if nothing else works, but e-cigarettes still likely carry an increased risk of periodontitis. So the consensus was that smoking cessation, to stop altogether, would be the end goal, and that we still do not know enough about e-cigarettes to really make a recommendation to move over to them. it must be understood that these products are not one homogeneous group, but there are quite a lot of different methods to consume tobacco replacement products using these things, and we do not really understand what all these products really contain and what the end effects of these products are. So if you're interested in that topic, there's a very nice, very comprehensive review by Christoph Ramsayer from Switzerland, who's one of the experts actually in smoking cessation programs in Perio, who summarized what we know thus far. But it's I wouldn't say it's enthusiastic when it comes to alternatives to smoking.
That's great. No, I'm sure that answers the question. A question coming in specifically, I think you did actually touch on the answer a little bit, but is there a time frame where you wait before moving from step 1 to step 2? Is there a hard and fast rule? Do you have any thoughts?
There are very few time frames mentioned in the guidelines, which is something that I quite like, because the guideline is not supposed to be a cookbook where you can shut off your brain, and it's also not a collection of laws or regulations. So it's not about you getting sued by not following it, or you shutting down your brain, but it's about giving you ideas what will hopefully work and what will possibly not work as well. And the important thing is that you get an idea how well your patient works with you. And in some patients, you get this idea rather quickly. In others, it might take some time. I just mentioned, but this is not guideline, this is just me, myself. I tend to do, even in those who have fantastic hygiene and that are fantastically working with me, I do at least 2 sessions just to get an idea of how they behave between session 1 and session 2, whether I see differences, whether they can actually use those tools. So if you introduce a patient for the first time in his or her life to the use of interdental brushes or any other interdental maneuvers, it's quite likely that they will not really know how to use them, and it will not be so easy just to do a single session. At the same time, it must be realized, and I think I've now shown this stepwise diagram again, that you do not stop fully with step 1. You keep keeping the patient clean, and you keep reminding the patient that to control smoking, to control diabetes. So also step 2 and step 3 include the measures of step 1 that will be running in the background. That means if you have a patient that has been substantially instrumented, it's not the time to neglect local risk factors. So if you see that this patient is building up a lot of superficial plaque, you bring in an additional round of PMPR, even though the patient has successfully climbed the first step at some point.
That makes perfect sense. I mean, on on that point, that brings us quite nicely on to the next question. It's a question that I'm being asked quite a lot at the moment online and on courses. Should the term PMPR be used now instead of scale and polish in the primary sector?
Well, I personally would think so, yes, because I can see a lot of ramifications of the use of something where there's no evidence base. So I can tell you from other countries, because you know that I'm an expat that has worked in a lot of different jurisdictions, and one common situation is that there is a certain trend in the gutter press to decry the greedy dentists that are doing non-efficacious measures such as scale and polish in healthy ones, for example, where there's very little to no evidence that it actually brings a big benefit, just to make more money. The German version of scale and polish, you can enter in Google and combine it with another keyword like rip off, and you'll get like tens of thousands of hits where people are fuming about being ripped off. And I've just heard from a colleague of mine who had a vet inspector in his practice in Britain, by the way, and the vet inspector had the idea that everything that's cosmetic, that is just about looks and about smelling nicely, is something the colleague should please pay a vet on. And
Oh,
he's
wow.
bringing this idea in for white fillings and also for scaling and polishing, because it's about polishing, about looking nicer. So PMPR is something with the strong scientific backing, and it's a medical, not a cosmetic procedure. So I wouldn't mind to get rid of scale and polish altogether.
Yeah, I think that last point, I think for me, is the most important part. If you're scaling and polishing literally just to remove stain, it's of no clinical benefit. Whereas what you're describing here is part of a stepwise approach following a diagnosis of a disease, and like you say, at that point it has a role, and it's more than just the 3-to-3 scale and a bit of a tickle with some proface. It's a very thorough process rather than something that's a cursory 2-minute job. So I think the difference is the difference between medical and cosmetic. I think I agree with you totally.
Moritz, can I ask you a question?
Yeah,
thank you for
absolutely.
the lecture. Excellent lecture, really informative, and I really enjoyed it. And yeah, thank you. It's very clear. I wondered if you could just talk through the PMPR for supragingival and subgingival.
That's an important, interesting point, and I know that we have discussed this in detail. So the way PMPR is defined, it is per definition, first of all, a maneuver that you do in the supragingival area. So the patient opens the mouth, and typically your hygienist, it's most often it's not the dentist, it's the hygienist, will start to tackle all visible soft and hard deposits. And this might include those in the gingival area, because most of us will know that there can be quite a lot of subgingival calcareous particles looking at us from the entrance, from the orifice of the periodontal pocket. And it's understood that during step 1, you will remove everything that is visible and reachable, but you should not reach into the subgingival area. Whilst there might be the difference that during SPT, and I think this is what you are referring to, you might extend that removal of everything you can reach and see to the few residual pockets that might still be there at the end of periodontal treatment, if that answers your question. I understand that it's an opaque thing to bring in new words, and Ian will bring in the new word subgingival instrumentation next time, so it's getting even more confusing. So we're not getting only rid of scale and portion, but we're also getting rid of RSD, to be fair.
No, thank you, Moritz. And for everyone listening, we are introducing new words, as Moritz has said, that we'd like to bring into our vocabulary. And we are going to dedicate a section of the BSP website on these keywords so that we define them clearly for you. Adollopment and PMPR in particular, we'd like to talk about, because we've written this in the flowchart for you, and we'd like to make it very clear what we're saying. So thank you, Moritz.
Okay, next question, but not the easiest question to answer, but again, we'll all have our thoughts on this. How do we avoid being accused of supervised neglect with our patients if they do not buy in and take responsibility for their health? So if we're providing step 1 treatment and there's no buy-in from the patient, how do we move to step 2? How do we avoid being accused of supervised neglect?
That's an excellent question that is indeed not fully covered by the guideline, because the guidelines are based on means, or on the average patient. So on average, and all the studies just report means and standard deviations maybe, on average you would try your very best to get this patient to adherence. But I'm very well aware that there might be situations where this is difficult, and there might be some people making the case that, for example, a person with a lot of pockets might just have more supragingival plaque, because there's a connection between the extent of the subgingival plaque and the amount of supragingival plaque, so that you could make the case that this person actually does not have any fault in this, so it might not even be intentional. So typically, if I have a patient with lack of adherence measured by not really reducing his or her levels of plaque, I would reinforce. And I did not, in my career of now 16 years as a dentist, encounter a person that would resist me for so long, to be fair. I just went on their nerves that much that I saw improvement. Important, and this is also, as I said in the flow chart, there you might not want to be as strict as the Scandinavians and say, well, if you don't achieve 20% plaque index, you get out of the door. We do recognize even more modest improvements as indicated by this delta of 50% improvement. So if a patient comes in and you have 100% plaque index and this patient goes down to 45, that is already a sign of proper engagement.
Yeah,
I'm with you that this is a difficult one. Huh?
I think just from a BSP point of view, the one thing people have to remember, the second paragraph of the BPE document actually talks about we can deviate from clinical guidelines in with testimony of where there's a lack of patient engagement. I think if you are going to withhold treatment or defer until engagement buy-in, your documentation just has to be very, very thorough. Patients also have to know that they're not moving to the next step and it's their fault that's holding them back from that next step. I think that's really very important. But I think providing treatment in the absence of clinical buy-in is potentially, we know, a waste of time, isn't it? I think also, those of you, there's lots of questions coming in about NHS, and it's difficult to bring in NHS specific questions tonight. I think I would encourage you all to have a look at the BSP website and the Healthy Gums Do Matter protocols if you're in NHS practice, and the concepts that they use of engaged and non-engaged patients. It's a particularly useful way to manage periodontal patients on the NHS using the UDA system. But we don't have time to bring that in tonight. It's slightly off topic. Next question. The question comes in relating to diabetes. Did the group look at the stable or unstable diabetic, and also between the difference between type 1 and type 2 diabetics?
That's an important one. They are similar to the situation with the smoking guideline or the appraisal of smoking guidelines. There was an appraisal of literature on the different ways to achieve control of diabetics, and this is predominantly focused on type 2 diabetics. But if you go back to this very nice Demo et al. 2012 prospective cohort study, I think it beautifully showed how both type 1 and type 2 diabetes share the same characteristics, so that you can see a direct relationship between the quality of diabetes control and future attachment loss. So the worse they're controlled, the more attachment loss they will have. So the not properly controlled type 2 and type 1 diabetics had as much as 8 times as much average attachment loss over 5 years than the non-diabetic. And this goes for both forms. It's just that the confidence intervals, so the measure of how sure we are about the data, the confidence intervals are larger in the type 1 diabetes patients because we have very few in comparison type 1 diabetes patients in comparison to the type 2 diabetes ones. But the diabetes data is very hard, and it's pretty much a dose and effect relationship. So the better we get, or the more we press the sugar levels down, the better it is for perio. On the same way, it must be understood that you cannot suppress glucose levels as much as you want, because there's also an inherent danger there. And this is also one of the reasons why the controlled diabetics are actually a little bit worse off in comparison to the non-diabetics, because there's also the danger of hypoglycemia, which can be deadly in certain cases if you fall into coma and you're not found in time, you might pass away. So a lot of diabetologists make the call that they'd rather not suppress HbA1c that much for safety reasons. They would accept certain higher rates of periodontal attachment loss and higher complication rates.
That's great, thank you. We've sort of answered this, but sort of haven't. So it's talking about when we reevaluate step one. So you mentioned that step one would typically be more than one appointment in your clinical practice. Would you have a week between appointments, 2 weeks, a month, 3 months?
That's a good. So my typical thing is that a patient comes in, gets at least 2 appointments. The first appointment is a discussion on the risk factors and an oral hygiene instruction that is maybe not 100% thorough, depending on how much the patient has actually done. Typically, it's brushing techniques, it's choice of toothbrush, it is typically selecting some interdental brushes, and it would include a pretty thorough PMPR. And then I typically ask to see the patient again after 2 weeks. So it's a range around 2 weeks that would allow us to get a good idea of how much buy-in this patient has brought. And at the same time, it would allow for a couple of days of training experience for the new measures the patient has to bring in. At the same time, it would be reasonably quick to allow us to progress with the periodontitis treatment swiftly. So it's not a good idea to focus on systemic risk factors only for months and to neglect the treatment of the periodontal pockets. But we need to have an idea of how well the patient engages. And typically this is at least 2 sessions, and my idea is to do them 2 weeks apart. And if you get the idea in the second session that this is not good enough, maybe the patient has manual problems, there's a lot of new stuff appearing and that you need to PMPR away, you may want to add another appointment, see the patient again another 2 weeks later, and reevaluate whether it's now good enough. And basically, the second you have the idea that this patient has worked with you properly, that everything in terms of local and systemic risk factors that it can control has been addressed, you can progress to step 2. And as I said, this is something that Ian Chappell will talk about in more detail. There are a lot of interesting surprises, maybe even controversial topics in step 2. I think it's one of the most interesting parts of the guideline. So I would suggest to everybody listening tonight to also tune in on the 26th for that thing. I will surely do that.
You're a great salesman for the future webinars. You can come again, Moritz. That's great. So this is a question that I'm sure it's very serious, but also slightly tongue-in-cheek. For the last few years, we've sort of moved away from talking about plaque, and we all talk about biofilm. Is there a reason why they've called it PMPR and not PMBR? As in, why is it professional mechanical plaque removal?
Yeah, that's a very good question, and I agree. So I think the reason is that this term is not entirely new. So it comes from an earlier consensus meeting that was before my time in this function. So I couldn't avoid it. So it was done in 2015. I don't know, Nicola, have you been there in 2015?
I have to admit I was, Moritz. Yes.
And it's all your fault. So
yes,
you're right. The only plaques we're talking about now are the plaques in the heart. So speaking of the atherosclerosis video I had at the beginning, and but I think it sounds quite nice. PMPR is something that we can use even as a verb to PMPR. Yes, Nicola, sorry, I had interrupted you.
No, not at all, Moritz. You're absolutely right. I think it's a great question, actually. Not heard that one before, but I think one we should repeat, Moritz, at the next guideline meeting. I think it's a great question. I think it comes from historically from, as you say, the 215 workshop, mainly from Leonardo Trombelli's work.
Okay, so we may have just had
Italians.
We may have just started the first revision of the BSP development, and we haven't even launched it yet. So That's
Well,
yeah,
that's
very
something that brings me to something. Before we stop, because it's 29 already, Ian, I have not, mea culpa, I have not mentioned one of the most important factors in guideline development, and this is the revision process. So indeed, if there's anything new happening, so if tomorrow there would be a new published randomized clinical trial with fantastic results for a new method, we would be obliged to update our guideline, and we should be updating our guideline in regular intervals. So we are thinking to do that together with the EFP, because they have the muscle to do that and need to write all these 15 systematic reviews again in an interval of about 5 to 10 years, depending on how much new stuff actually appears. So there is an inherent update mechanism in this process, which is different from all other consensus meetings we had in the past that were typically not updated.
Yeah, and I think that is this one of the main strengths, isn't it? It's a sort of living document, so to speak.
Yeah.
Yeah,
it is a strength and a weakness, because I'm responsible for quite a lot of guidelines, and it's giving me tremendous headaches, because it's a little bit of a problem, because imagine you were the manufacturer of an adjunctive measure that maybe did not get recommended, or where the guideline actually says you shouldn't use that, and you brought out a new study tomorrow with 20 patients. So you would try to pressure the guideline group into changing their recommendation. So we have to be a little bit strong, and we have to be quite strict and also to be quite impartial to be fair in this process. So typically it's this 5-year interval that makes sure that new stuff gets integrated and we're staying up to date. But it's not as easy as it sounds, because it's a tremendous work that took the better part of 2 years now.
Yeah.
Can I add to that, Moritz? As you very well know, that when we looked at the UK guidelines, and as you would the German guidelines and the Spanish guidelines, from the EFP workshop, which was probably at least 6 months, if not a little bit more, we did look at all the new papers, and we looked at that for our guidelines. So we already started to do that, didn't we?
Yes, but it was already quite a painful process, only to do that for a couple of months.
Indeed, indeed. Yes, I have some grey hairs. Yes.
Yes, you were one of the authors. So you,
yes.
Well, from experience, you know that it was not as nice as you would think. So, in summary, guidelines, especially these high quality guidelines on the highest level that there is worldwide, and we're supported by a former president of Guidelines International, which is the professional body of people running guidelines in this undertaking. They offer a lot of chances, but they are also making sure that the amount of my gray hair is increasing day by day.
No.
Yeah. So, what can you say to that? It's the good thing that all our listeners tonight cannot see me due to the issues with GoToWebinar, but so I can maybe get some proper color in my hair, but yeah, it has been not always easy.
He's joking, everyone.
I'm sure he is. I'm sure, yeah, devilishly good looking. Yes. So there's lots of questions coming in with lots of repetition and lots of sort of NHS rules and regs stuff that we can't really get into tonight. Again, any NHS related question, I think look at the Healthy Gums Do Matter stuff on the BSP website. By all means, email into the society. We'll always field questions where possible. But I don't want to take this away from the topic in hand tonight, because it's too important. I think we've covered pretty much everything that's come up tonight. So I'm going to sort of, I think, bring the evening to a conclusion. I know Nicola would like to say a few words before we go. I would like to thank everybody for listening and thank Moritz for an excellent presentation. But I will hand you over to Nicola for the last few words.
Thank you, Ian. And thank you, Ian. You are an amazing host and moderator. Thank you, as always. It's a great pleasure working with you. Thank you, Moritz. A superb lecture. I think it's given everybody a flavour of what's to come, and we will encourage you, as Moritz has said, to listen to Ian Chappell on the 24th of February. These guidelines are really important because it's the first time that we've got evidence-based guidelines, 62 recommendations from 15 systematic reviews. That's a working document that we can use and work with in the future. So it should really influence and improve the overall quality of care for our perio patients. So Moritz, thank you. A great pleasure to be with you this evening, and a fantastic, clear lecture. I would like to thank GSK. I think they have been amazing to support the BSP for the flowchart. I know you haven't seen this yet, but we've been working on this and with interviews for social media. The flowchart has a surprise for you. I won't spoil that, but we're really excited about it, and it's nearly ready to come out, and we will distribute that to every practice in the UK. And I have to thank GSK for their support in both filming the flowchart and the distribution. So, huge thanks. And as Ian and Moritz have said, the most important people are you. Thank you for listening, and we are trying to change the UK's oral health, and it's you that will help us do that. You're the most important people here, so thank you so much. Thank you, Ian.
That's great. Thanks, Nicola. So all that leaves is me to say good night to everyone. Don't forget to register for the webinar in 2 weeks' time. And yes, thanks for listening, and we'll see you next time. Take care. Bye.
Bye-bye, everybody.
Bye.